All right, welcome. So, this lecture is going to be about stepping back from the surface behaviors and learning how to think about sexual symptoms and compulsive behaviors in a disciplined way. This is one of the most common things that present to both primary care and psychiatry. And in this lecture, I'm going to talk to you about sexual dysfunctions and paraphilias and the process of addictions, because some of the areas are where clinicians feel least prepared to help with. Not because they're rare, but because they sit at this intersection of biology and learning. And when we introduce things like shame and meaning and arousal, they often show up in primary care, they get referred to psychiatry, and then it stalls out because once we make the evaluation, we basically just stop at labeling it. So what I want to offer you here is this conceptual bridge. We're going to do an integration of the DSM-5 with the research domains criteria so that we can have this dimensional understanding. And then I'm going to present to you this imprinted arousal pattern framework to try and explain why certain behaviors persist even when they're unwanted. So the through line for this lecture is going to be simple. Many of these behaviors are not about excessive desire or even a moral failure. These are about arousal becoming a regulatory solution. So once you see that, then the assessment and treatment planning changes. All right, so the first thing I want to do, these are our objectives. I want to clarify what is meant by the imprinted arousal pattern. So IAP refers to this conditioned coupling between physiological arousal and emotional state, meaning, and expectation. Over time, arousal becomes linked to relief, safety, vitality, control. Once that pairing is established, the nervous system learns to seek it automatically. Next, I'm going to situate for you the DSM diagnosis within the RDoC domains. Now, the DSM tells us what clusters of symptoms qualify. The research domain criteria helps us understand which systems are actually dysregulated. Is it the reward system, the threat, the arousal, the cognition, the social processing? This matters because two patients can meet the same DSM criteria but require very different treatment interventions. And I'm also going to spend some time distinguishing between medication-induced sexual dysfunction from IAP-driven patterns. And this is clinically critical because if the arousal collapses after starting the SSRI, that's not the same problem as a long-standing learned arousal loop. So treating those as equivalent leads to frustration for both the patient and the clinician. Now, a major clinical skill we're going to practice is going to be in differentiating between also what is a kink, a fetish, and what makes something a disorder. Now, kink refers to an optional enhancement. Arousal flexibility remains intact. Remember about that flexibility. Fetishes refers to a learned requirement, meaning no flexibility, and arousal becomes very narrowed. This is what makes it a disorder. The disorder is defined not by the content, but by the distress and in the impairment and the loss of mental flexibility and the amount of risk associated with carrying it through. So this is not meant to be a moral or an aesthetic distinction. This is purely a functional definition. And then we're going to apply the same logic when we do treatment planning. So rather than reflexively suppressing your libido or a behavior, we're going to think about this in terms of which research domain criteria needs to be targeted. Because sometimes the problem is indeed excessive arousal. And sometimes it's chronic under-arousal. And sometimes it's a threat sensitivity just masquerading as desire. And finally, we're going to address this thing of risk assessment in the paraphilic disorders, because this is the often driving reason for the psych consult. What risk threat do we need to conclude from this? So this includes things like evaluating consent, capacity, escalation behaviors, situational risk. And this is where that clinical psychiatry starts to overlap with a little forensic reasoning, and where conceptual clarity is essential to avoid both overreaction and minimization. So by the end of this lecture, the goal is not that you know all the paraphilias, but that you can formulate clearly and speak a little more precisely and intervene ethically when the case shows up in real practice. So that's my goal for you in this lecture. Well, now the reason clinicians struggle with sexual symptoms or compulsive behaviors, it's not because the case is unusually complex. It's because the models we're usually trained in leave important questions unanswered. So traditional diagnostic systems are good at naming what the behavior looks like at the end point. They tell us whether criteria are met. What they don't explain is why this particular stimulus behavior scenario became erotically or compulsively charged for this individual. And RDoC moves us closer by focusing on systems reward, threat, and arousal. It's going to be reward, threat, and arousal. But even that framework can feel a little incomplete in practice because it describes circuitry. But it doesn't automatically explain how that circuitry was shaped by lived experience. So two patients can have a similar reward system, dysregulated, and yet they pursue completely different behaviors. On the psychotherapy side, we say insight alone is often insufficient, and then patients may understand their history and they may name their trauma and they'll articulate meaning, and yet still they find that their body responds automatically. That's because arousal conditioning operates below the narrative awareness. So knowing why something happened does not undo what the nervous system learned to pair with relief or safety. And medication-only approaches have this parallel limitation. It may suppress the libido and dampen the reward or flatten the affect, and it may reduce symptoms temporarily, but it often leaves the patient feeling disconnected or numb, and that underlying learning remains intact. So when medication is stopped, what happens is the pattern frequently returns, and then the central clinical risk here is misinterpretation. So if we don't understand what the patient's arousal system learned, we can easily mislabel an adaptive, though now maladaptive, regulatory strategy as a pure pathology or an impulsivity or some sort of moral failure. So that's the gap that the imprinted arousal pattern framework is meant to fill in. It explains how arousal, meaning, and relief became linked so that the diagnosis and the psychotherapy and the pharmacology can work together rather than at odds with each other. Now, before we apply the IAP, imprinted arousal pattern, to specific disorders, I need to share some language with you regarding the systems that are actually involved. So this is where RDoC becomes especially useful. This is not meant to be a diagnostic replacement, by the way, but just simply a way of organizing what is dysregulated. So when you see compulsive sexual behavior or a process addiction, right, that could be gambling, shopping, etc., the positive valence system is almost always involved, but not in the simple sense of the pleasure drive. Many patients continue behaviors they no longer enjoy. How many have said, I'm only doing this to just feel normal? Well, what's driving this persistence is often this wanting without liking, habitual reward seeking that has become decoupled from pleasure. In other words, you've done it so long that this is just a habit at this point. You're on autopilot. The other is the arousal and regulatory domain, and this is equally central in this. So sexual and compulsive behaviors are among the fastest ways to shift the autonomic state. Now, for some patients, arousal is how they escape numbness. For others, It's how they discharge the tension or the anxiety. Now, if you don't assess baseline arousal state, say under-aroused, hyper-aroused, or unstable, you're going to misread the motivation. The negative valence system comes into play when behavior is driven by threat reduction rather than reward. So, for example, if they feel shame, anxiety, fear of abandonment, or some sort of internal distress that often precedes that compulsive behavior, then in those cases, the behavior is less about desire and more about avoidance of some negative internal state. And finally, the social process also matters because sexual arousal rarely develops in a vacuum. You see, attachment patterns, early relational experiences, humiliation, exclusion, or secrecy, they all shape what becomes erotically or compulsively charged. Two patients may present with identical behaviors but dramatically different social meanings. So the value of RDoC here is that it forces you to ask, which system is dominant in this patient right now? And then the imprinted arousal pattern then builds on that by explaining how these systems became linked through learning. So as we move forward, you'll see that the effective treatment planning depends less on suppressing the behavior and more on targeting those specific domains that are sustaining the behavior. Now, at this point, it's very important to be clear about what imprinted arousal patterns are, and just as importantly, what they're not. So, IAP is not a diagnosis. It's a learning construct. It describes how the nervous system comes to pair arousal with affect and meaning and expectation until that pairing becomes the default pathway for activation and inhibition or compulsion. Now, in other words, it explains how sexual or compulsive patterns form, not whether someone meets criteria for a disorder. This also is not a model limited to just paraphilias or so-called atypical sexuality. This is the same learning process that applies to something like erectile dysfunction, or inhibited or hypoactive desire, or compulsive pornography use, or gambling, or workaholism, or shopaholism. The nervous system does not distinguish between vanilla and non-vanilla. It learns what works, and while trauma can certainly contribute, the imprinted arousal pattern is not trauma exclusive. You may have had a very enjoyable atraumatic experience that set up a maladaptive pattern. So these patterns can form in the context of neglect, chronic stress, attachment disruptions, or simply just repeated exposures during some period of emotional vulnerability. The key variable is not the severity of the event, but what arousal was paired at the time. So the core idea I want you to hold on to is this. This is a learning imprint, not a character flaw. Once you approach it that way, then this clinical stance is going to shift immediately from judgment to curiosity and from suppression to reorganization. So keep this in mind as this presentation moves forward, okay? Keep this very clear. Desire is motivational wanting. Arousal is physiologic activation. The IAP pathology lives in the arousal, not the desire. So you can be aroused by something you do not desire because it's a physiologic nervous response. Arousal is not a statement of preference or values. The body can activate in response to threat, novelty, shame, fear, power. If I scare the hell out of you, you've just gotten aroused. And those conditioned cues, even when the person experiences no conscious wanting. You can find the stimulus aversive, and you may feel distress about it afterwards. It didn't change the fact that you were autonomically aroused. And this is especially common in trauma, right? This conditioned compulsive or paraphilic pattern where arousal is functioning as a regulation rather than an attraction. This is how come during a sexual assault, the person being assaulted may become physiologically aroused. It doesn't mean they wanted it. You can also desire something without being aroused by it. And this is why I'm paying a lot of time distinguishing between desire and arousal. Desire is motivational and relational. It deals with things like wanting intimacy, wanting connection, meaning, some particular partner. If the nervous system is inhibited, say, by anxiety, depression, a medication effect, some sort of autonomic disorder or shutdown, another competing stress of physiology, the desire can be present and then the arousal fails to activate. This is common in people who are depressed, those on SSRIs, people with performance anxiety, right? I desire to do well, but autonomically I'm shut down and I can't perform. And also relational burnout. You can have the desire without the arousal. Now, if we look at how these patterns form developmentally, the sequence is pretty consistent. So this often begins with an early arousal experience, which might be sexual discovery or some sort of physiologic activation or a novelty or any sort of intensity. And on its own, that doesn't determine anything. What matters is the emotional context surrounding that arousal. If there was stress, shame, fear, loneliness, or some sort of threat frequently has co-occurred. So then what happens is you have arousal happens and it cuts through those states briefly. Now when that behavior or stimulus is then repeated under emotional load, then the nervous system starts to take note, and that repetition isn't about pleasure, it's about regulation. The body learns that this changes my state. So over time, through basic nervous system learning, that pathway then consolidates and arousal becomes associated with safety and relief and grounding and even identity. And at that point, the pattern doesn't even feel optional anymore, it feels necessary. So the result is that arousal is no longer just sexual, it's become this regulatory tool. And that's why attempts to remove the behavior without addressing its function will often fail. Now this brings us to this clinical pivot point. What regulates becomes eroticized. Now if arousal provides safety, then danger, risk, or secrecy become charged. If arousal provides soothing, then tension or distress may precede desire. If arousal provides an identity, then very specific cues or scripts may feel non-negotiable. This is why focusing only on fantasy content misses the point. The content is the vehicle, not the function. So clinically, treatment has to target what the arousal is doing, whether it's regulating anxiety or restoring vitality or discharging tension or stabilizing their identity. You see, suppressing desire without replacing its regulatory role will often leave patients more dysregulated, not less. So as you move into the disorder-specific material, keep this framing in mind. Your task is not to decide whether something is normal or abnormal, but to ask the question, what did this nervous system learn and why did it keep it? That's the question that makes this ethical, effective intervention possible. Once you understand IAP as a learning construct, its value becomes really clear. So this functions as the missing bridge between diagnosis that otherwise feels fragmented and sexual compulsivity. So behavioral addictions and impulse control disorders and trauma-related dysregulation, those often get siloed into these separate categories. Clinically, though, you'll notice how often patients move between them across the lifespan. And what IAP offers is a way to understand that movement. It's not a diagnostic drift as much as it's a shared regulatory mechanism that gets expressed through different behaviors. So when arousal becomes the primary way of regulating the nervous system or regulating a threat or reward or identity, the specific outlet can change while the underlying imprint remains stable. So that's why someone may stop gambling and start compulsive sexual behavior, or move from sexual compulsivity to rigid control or avoidance. The form changes, but the function doesn't. This also helps to explain why treatment resistance is so common. You see, patients may be motivated and have insight and comply with your medications, yet the behavior persists. That's not because they're oppositional or unwilling, it's because the arousal imprint is still active. It's still doing a job that the nervous system really relies on. So the clinical question really shifts. Instead of asking, why do they keep doing this? The more useful question becomes, how did this nervous system learn to organize arousal in this particular way? That reframing alone changes how you assess how you talk to patients and how you plan treatment. Now, there are two concepts here of trauma reenactment and trauma play, and this is where that distinction becomes especially important when we talk about trauma-related sexual behaviors. So from the outside, trauma reenactment and trauma-informed sexual play can look very similar. The difference is not the behavior itself, but the relationship to agency and consent and outcome. So in reenactment, the behavior is rigid and compulsive. The nervous system is pulled toward threat because threat is what activates a familiar arousal pathway. There is often a sense of being driven, stuck, or overwhelmed afterwards. The goal may be mastery, but the result is usually re-traumatization. In contrast, though, trauma play or scene-based sexual expression, this is an intentional and bounded activity. Not bound, bounded. Arousal here is paired with safety cues and consent and aftercare rather than the collapsing agency. It expands it. The nervous system here experiences the activation without the loss of control, which can be genuinely corrective. So clinically, this distinction matters because it prevents mislabeling consensual behavior as pathology, or conversely, missing harm because the content appears normalized. What matters is whether the behavior increases flexibility and integration and safety or narrows it. So a useful shorthand here is this. The reenactment happens to the person. The play is something the person does. This brings us to why psychotherapy alone often falls short. So insight alone does not recondition arousal. Patients can fully understand their history and tell you about their trauma and make meaning of their patterns, and yet still find it hard because their body is responding automatically to cues. That's because the conditioned autonomic responses are not governed by narrative understanding. Similarly, reducing shame is necessary, but it's not sufficient. Shame reduction may improve their self-esteem and engagement, but it doesn't automatically uncouple the arousal from its learned targets. Patients often feel better about themselves while still feeling hijacked by the same patterns. This doesn't mean psychotherapy has no role. It means its role must be precisely targeted. You see, talk therapy that does not address arousal conditioning risks colluding and frustration. So both the clinician and the patient know why the problem exists, but neither can change how the body responds. So as we move forward, we keep this hierarchy in mind. Effective treatment requires aligning the insight with relational safety and some sort of somatic regulation. And when appropriate, pharmacology can have a role. So IAP gives you a framework for deciding which lever to pull and when. Now, narrative repair addresses explicit memory, the story the patient can tell. But conditioned arousal lives in implicit memory systems. That's the amygdala and the striatum. That's why you see the relapse with rationalization patterns. The behavior returns, but the explanation changes. Insight without reconditioning is like knowing what you're allergic to while still being allergic. Knowledge alone doesn't change the reaction. So medications are valuable tools, but we need a little prescribing realism. So SSRIs can blunt libido and reduce physiological intensity, right? They do not change the erotic meaning attached to the stimulus. So antipsychotics can reduce salience, and mood stabilizers can reduce volatility. None of these is going to erase the original imprint. So when medications are stopped, the symptoms will often rebound because the underlying learning was never restructured. This is not a failure of medication, it's just a category error. So asking the medication to do the job that they were never designed to do. All right, so therapy alone doesn't work, medication alone doesn't work. What in the world are we going to do? So the clinical target has to shift. Symptom suppression focuses on less desire and fewer urges and silence. It works temporarily, but carries a really high rebound risk. Arousal training and retraining focuses on flexibility. It builds a new adaptive pairing. It prioritizes the function over the content. The long-term goal is not erasing desire. It's restructuring how arousal is organized so the patient has a choice instead of a compulsion. So up until now, most of the clinical training has emphasized symptom checklists, essentially, right? We're doing DSM psychiatry. But what behaviors are present, how often do they occur, and whether they meet diagnostic criteria. So if you take an IAP informed evaluation, and I'm going to ask you to shift one level deeper. We're no longer just cataloging the behavior, we're going to try and understand what arousal is doing for this nervous system. The first question is about developmental onset. We're not asking when did this become a problem. We're asking when did it first feel regulating or soothing. That distinction matters because many imprints form before the behavior is experienced as distressing. So early relief is often the clue to why that pattern persists. Next are these emotional antecedents. So before the urge shows up, what state is the person in? Are they anxious, lonely, bored, feeling ashamed, dissociative, wanting to avoid? This tells you whether the behavior is regulating arousal or avoiding threat or restoring coherence because it's familiar. It's not just chasing pleasure. And the third question targets the immediate meaning. So in the moment, what does the behavior mean to the patient? Does it mean control, relief, belonging, power, being seen? So meaning is critical because the medication can reduce the intensity, but meaning is what keeps that pathway alive. And then finally, we're going to ask about the regulatory function. What happens when the behavior is removed? Does the anxiety spike up? Does your identity now feel unstable? Does the person now feel empty or unmoored? If removing the behavior destabilizes the system, that tells you it's functioning as regulation, not simply impulse. So taken together, these questions integrate directly into formulation. They move us away from asking only what the patient does and to understanding why this nervous system learned to organize arousal this way. Kink versus fetish versus fetishistic disorder. So this slide is about making distinctions that clinicians must get right. The difference between the variation, the focus, and the pathology. I'm not here to police your sexuality. We are here to assess function, flexibility, and impairment. So on the left here, you see kink. This is a variation. Kink refers to consensual interests or preferences that are optional, context dependent, and flexible. Importantly, kink enhances the intimacy rather than replacing it. There's no distress, there's no impairment, there's no loss of agency. So from a clinical standpoint, kink alone is not a pathology. In the center column here you see fetish. This is a clinical descriptive term, not a diagnosis. So a fetish involves an erotic focus on a specific object or body part, and it may become necessary for arousal. Over time, the erotic focus can narrow. However, a fetish is not pathological unless it causes distress, impairment, or loss of choice. On the right side of the screen, you see fetishistic disorder. This is the pathology. So here, the arousal becomes rigid, meaning it is impossible without the cue to become aroused. There is a clinical significant distress associated with this, and there's often shame, and there's often impairment in work or a relationship because of this. That's what rises it to the level of a disorder. And compulsivity may be present in some cases, and there's a risk of non-consensual behavior in fetishistic disorders. And this is where the diagnosis is appropriate. So the key distinction across all three columns is not the content or the interest. It's the flexibility versus the rigidity. It's the choice versus the compulsion. It's the function versus the impairment. That functional lens is what allows us to differentiate between healthy variation from a clinical disorder. Now, this slide answers a critical question. When does a sexual pattern become a disorder? And the answer is not based on taste or culture or even the clinician's comfort level. It's based on these 5 clinical thresholds. And the first threshold is rigidity. Now we ask whether there has been a loss of flexibility. Can the person experience intimacy or arousal without this specific cue or behavior? So rigidity signals that the nervous system has narrowed its options. The second threshold is distress. Now here we distinguish intrinsic suffering from external stigma. Is the person suffering because of the pattern itself, the shame, anxiety, loss of control, or only because of how others might judge it? Only intrinsic distress counts towards the diagnosis. The third threshold is level of impairment. Now we look for measurable impact on work, relationships, physical health, or daily functioning. A pattern that does not impair functioning is not, by definition, a disorder. So the fourth threshold here is compulsion, and this is where choice begins to erode. We see escalation in frequency or intensity, inability to delay urges, or repeated behaviors despite negative consequences. That's where you might even call it an addiction. Right? That's the definition also of addiction. So compulsion reflects that loss of regulatory control. And the fifth question, the fifth domain here is this threshold of harm or consent. If anyone is being harmed or coerced or involved without full and informed consent, then that clinical question is settled. This is a pathology. This is no longer about variation. It's about pathology and risk. So the key takeaway is this. It's not the content that defines the disorder. It's these 5 thresholds that do. So our job as clinicians is to assess the flexibility, distress, impairment, compulsion, harm, and you have to be very consistent without moral drift. So why does this framework matter, especially for psychiatric nurse practitioners and not psychiatrists in general? Well, psych nurse practitioners sit at this unique intersection of medication management and therapeutic formulation. And this is exactly where most sexual and compulsive presentations break down. First, this approach integrates meds and therapy thinking. And as psych NPs, we do prescribe medications, but we also evaluate mechanism. And this framework allows us to understand what medications are doing at the level of arousal and impulse without pretending they're rewriting any meaning. It aligns the prescribing with realism, with psychotherapeutic insight. Second, it improves that diagnostic clarity. Instead of checking boxes or defaulting to moralized language, we ask functional questions. What does this behavior regulate? What happens when it's removed? This shift from the evaluation from what the diagnosis fits to what system is dysregulated. Thirdly, this thing supports trauma-informed and sex-positive care. So as psych NPs, you routinely will see patients who fear being shamed or misunderstood or over-pathologized. Well, this framework allows us to distinguish healthy variation from pathology without invalidating the patient's learning history or their erotic identity. And finally, this reframes the treatment target. We're not just suppressing urges. We are treating arousal systems, how the nervous system learned to organize and develop safety and soothing, identity and reward. Now we pivot to the sexual dysfunctions as defined in the DSM. Now these disorders are organized around functional disturbances in either desire, arousal, orgasm, or pain. These are not around moral or relational dissatisfaction alone. So diagnosis requires persistence and clinical significance, and symptoms have to last at least 6 months for all of these disorders, and it has to cause distress or impairment. Now, often the etiology is complicated because sexual dysfunction frequently will overlap with a medical illness or a medication or a substance use or some sort of severe relationship stress. So this is why it's very careful to do that rule out diagnosis of exclusion, the 6 steps I've been telling you about. And the guiding principle is this: distress is the hallmark of dysfunction, and variation without distress, that's not a disorder. So these criteria apply all across sexual dysfunction diagnoses. And the first thing we need to consider is duration. So symptoms must be persistent or recurrent for at least 6 months. Transient difficulties don't exactly qualify according to DSM criteria. And secondly, you have to have clinically significant distress. So without personal distress, there's no criteria for disorder. So regardless of partner dissatisfaction or some cultural expectation, they're not meeting criteria if they don't have significant distress. Third, there's the exclusion of other explanations. So the dysfunction must not be better explained by another mental disorder or severe relationship violence or even an acute stressor. Fourth, substance and medical conditions need to be ruled out. So if the symptoms are fully attributable to medication or substance use or medical illness, then the correct diagnosis becomes substance or medication-induced sexual dysfunction. And finally, you always have to specify lifelong versus acquired and generalized versus situational, and severity, of course. And this is where that rigor protects the patient from being mislabeled, hopefully, and protects the clinician from being overly simplistic. Now, this slide maps the common male sexual dysfunction disorders and diagnoses to the RDoC domains, and then it reframes them through the imprinted arousal pattern lens. So start at the left. The DSM and ICD labels describe what's happening. The RDoC gives us the systems that are involved. And then the IAP tells us what the nervous system learned. So look at the first one, erectile dysfunction. Now, the key issue here is not desire, but inhibition. Arousal becomes paired with performance fear or evaluation, activating the threat circuits. So the result is this autonomic shutdown, not a lack of interest. If you look at male hypoactive sexual desire, the imprint is different. So desire itself has been learned as costly or disappointing or unsafe. So then the nervous system dampens reward before arousal even begins. Premature ejaculation reflects the opposite pattern, hyperarousal. So arousal got linked to urgency and escape rather than modulation. So there's activation without regulation. And then delayed ejaculation, formerly called retarded ejaculation, shows arousal without completion. So often this reflects inhibition through shame or control or medication effects. So it says arousal is allowed, but resolution is blocked. So the takeaway, these are not failures of masculinity or willpower. These are learned arousal organizations. Now, this slide applies the same framework to the female sexual dysfunctions, where the relational and safety cues play a larger regulatory role. So in female sexual interest arousal disorder, desire is often contingent on safety and attunement or permission. Now, when those cues are absent, the nervous system suppresses arousal, not because desire is gone, but because it's conditional. So with female orgasmic disorder, arousal may be present, but completion is disrupted. So you might have vigilance or disassociation or some sort of impaired introception that interferes with staying embodied long enough to climax. The next one is genito-pelvic pain or penetration disorder. Penetration has been conditioned for some reason as danger. So defensive contraction occurs automatically outside conscious control. This now bundles vaginismus as well. Finally, there's substance or medication-induced sexual dysfunction, and this is important clinically because medications may not create the problem, but they can certainly unmask or worsen some sort of pre-existing imprinted arousal pattern by altering that arousal threshold. So across these diagnoses, the pattern holds. The symptom is not the problem. The problem is how safety and threat and meaning have been wired into arousal. All right, let's talk about erectile disorder through the lens of the DSM specifically, because this is our checklist that we're going to follow. So the DSM defines this as a marked difficulty in obtaining or maintaining an erection, or reduced rigidity, or and that situation has to persist for at least 6 months, and it has to cause clinical significant distress, and it must not be better explained by another mental disorder or severe relationship distress or some sort of substance-induced or medication condition. So in primary care, the classic presentation is it works when I'm alone but fails when I'm with a partner. And this is often paired with performance anxiety or avoidance or repeated checking behaviors. So from an IAP perspective, this maps onto an arousal threat imprint. So sexual arousal has become biologically paired with evaluation or fear of failure or anticipated loss of control. And then that pairing activates the sympathetic fight or flight response, which directly inhibits the parasympathetic erection reflex. The differential is critical, though, because medication or vascular causes, they produce global impairment, whether they're with a partner or alone or asleep, it doesn't matter. And usually it has a gradual onset. Whereas if this is an imprinted arousal pattern driven erectile dysfunction, then that means it's situational and sudden and cue dependent. So clinical action is going to follow that pattern. So if situational, then you want to prioritize arousal retraining and threat decoupling. But if it's global, then we have to proceed with vascular and the medication workup. Okay, so this slide now addresses male hypoactive sexual desire disorder. So the DSM criteria defines this as a persistently deficient or absent sexual or erotic thought or desire, judged in the context of age and life and circumstances, causing clinically significant distress. So patients often say, I just don't think about it anymore, or my partner wants sex, but I have zero drive. Now, common associations will include things like fatigue and burnout and anhedonia, or concerns about testosterone. So from an IAP framework, this reflects a reward dampening imprint. Desire has been learned as costly and disappointing or unsafe. So the nervous system proactively downregulates the anticipatory reward within the positive valence system to conserve energy and avoid a negative outcome. So before labeling this as a primary desire disorder, we have to rule out endocrine causes and testosterone and prolactin and medications and SSRIs and opioids and alcohol and major depressive disorder. So if anhedonia is global, then we got to go after the depression first. The key distinction here is that arousal isn't broken, it's been recoded as effort rather than pleasure. So premature ejaculation is defined as ejaculation occurring within approximately 1 minute of penetration before the individual wishes it to occur, and it has to persist for at least 6 months and present at most sexual encounters. Clinically, patients will report a sense of a loss of control or intense performance anxiety, or that it's over before it starts. And many avoid intimacy altogether to escape any sort of associated shame with this. In terms of imprinted arousal patterns, this is a hyperarousal escape imprint. So arousal here is linked to urgency and rapid discharge rather than modulation. So high arousal is interpreted as tension or threat that must be released immediately to restore regulation. In lifelong cases, this pattern is often neurobiological, with serotonergic set points playing a role. So SSRIs here are quite helpful. If this is an acquired case, these typically follow things of prostatitis, thyroid changes, or a newly learned anxiety-based imprint. So treatment follows the subtype. So pharmacologic support for lifelong PE, and then you cause targeted treatment plus stop-start retraining for acquired cases.
And the most common contexts are in the setting of SSRIs and SNRIs, but neuropathy and also if they've developed a highly specific masturbatory conditioning pattern, device, certain grip, certain stimuli, etc. The imprinted arousal pattern here is this arousal inhibition imprint with a partner, and the arousal is permitted, but for some reason completion is blocked, and this may be conditioned by some early life experience where release felt unsafe, or by medications that have raised the sensory threshold. But the key point here is that the desire and the arousal are intact, but the block occurs at the moment of completion. This vignette illustrates why distinguishing medication effects from an imprinted arousal pattern matters, because here the patient has been started on sertraline, is reporting never finishing with his partner, yet can ejaculate quickly when masturbating to very specific pornographic cues with a high grip pressure. And so what you have here is a mixed picture. The SSRI has increased the ejaculatory latency globally all the time, but has preserved this narrow function at high intensity cues, which suggests this imprinted arousal pattern overlay. So in this case, conditioning to pressure and visual stimuli rather than the relational arousal, and the medication-induced delay is globally dose dependent. So the IAP is context specific. When it's biologically mediated, it should be globally present, so biologically meaning medication. So what you do is the action has to follow the mechanism. If this is primarily an IAP-driven focus on, then you want to focus on desensitizing and changing the specific cues and resensitizing partner-based arousal. And if the medication, then you consider dose reduction or augmentation with something like bupropion or timing that might be useful. Now we'll talk about female sexual interest and arousal disorder. This is the DSM criteria, which is a mechanism-based interpretation. So on the left side of the screen, you'll see that the DSM criteria is recorded there. So the core requirement is a lack of reduction, a lack or reduction in sexual interest or arousal defined by 3 or more indicators. So what are those indicators? Well, those indicators include reduced sexual thought, reduced initiation, reduced excitement, or reduced sensation. You need 3 or more. Second, the symptoms have to persist for at least 6 months and must cause distress. Without distress, you can't have this diagnosis. So if everyone's content with the situation, this doesn't rise to the level of distress. The third is the symptoms can't be better explained by relationship distress or other stressors or substance-induced, because that exclusion criteria is explicit here. Now, the clinical presentation box, that highlights when this often shows up. You'll often see this postpartum or during menopause, that is major life changes, hormonal fluctuations, after a major relationship shift. Just getting a new job may perk the desire, losing a job may kill the desire. Patients commonly describe feeling broken or dead inside with respect to sex. On the right side of the screen, you see this mechanism of imprinted arousal pattern mapping. And the pattern here is in the positive valence and autonomic arousal and the social processing reward system. Okay, and so what the imprint is this relational arousal suppression. That is, desires become contingent on safety, attunement, and or permission. And all of that feels absent. So when you put the emphasis on dealing with that mechanistic contrast, then you will have to downregulate the desire, the arousal portion. So that's where the interventions are aimed. Now this slide is about diagnosis of a clinical vignette. So on the left, you see this vignette of a 32-year-old postpartum female with a history of child sex abuse who reports feeling physically shut down since childbirth. And her partner observes this dissociation during intimacy. Her own words are important. I want to want it, but my body just says no. So what is the imprinted arousal pattern analysis here? Well, the stress of the postpartum touch and demand has reactivated an early relational arousal suppression imprint. And sexual initiation is being interpreted as a boundary violation instead of desire. So the nervous system triggers this freeze response, resulting in shutdown rather than arousal. And on the right, you see these differential assessments here. The first, obviously, we need to consider medication-induced dysfunction, such as SSRI, SNRI. And these patients will describe global numbness and reduced sensation and reduced fantasy everywhere. Now, they can sexually engage, but everything does feel blunted. In contrast, if this was an imprinted arousal pattern, say trauma-linked distinction, or this becomes context-specific. So, for example, patients will describe a feeling of unsafe or frozen, and arousal is blocked by anxiety and vigilance or disassociation, particularly in partnered situations. Now, at the bottom of the screen here, you'll see this clinical action. If the pattern is imprinted, arousal-driven, then you need to focus on issues of safety and control and reducing those brakes before trying to increase the desire, because the accelerator may be pressed, but the brake system is overriding it, and that's the key distinction here. Now let's talk about female orgasmic disorder. Take a look here. The DSM-5 criteria are on the left side of the screen, and the core feature is this marked delay in frequency or absence of orgasm, or a significant reduction in the orgasmic intensity. Now, these symptoms have to persist for at least 6 months and cause clinically significant distress. But importantly, they occur on almost all sexual encounters. Roughly 75 to 100% of the time these are occurring. So in primary care, a patient may say things like, I get close, but I get stuck in my head. And this is commonly accompanied by frustration and then self-blame, and they'll say, I'm broken. Or this concerns that the medications may be responsible, and they may be, but you have to decide that. On the right side is this mechanism of imprinted arousal mapping, and the pattern comes to completion interference imprint, and this involves the positive valence and autonomic arousal and the cognitive systems of the research domains criteria. And physiologic arousal here is present, but the cognitive interoceptive pathway to peak is disrupted. They will report things like vigilance or spectating, disassociation. They might be doing repeated safety checks, which all interrupt the progress towards climax. Over time, the nervous system learns to halt arousal before the perceived loss of control that is associated and necessary for orgasm. The key takeaway from this slide is that the arousal and desire are not absent, but the completion is blocked. So this is female orgasmic disorder, where we move from a definition into some clinical reasoning. Now at the top here you see this clinical vignette. This is a 36-year-old woman raised in a strict religious environment where sex was never discussed, and she may report watching herself during intimacy. We call that spectatoring. That's when they see themselves hovering outside their body and they're watching the thing and they're concerned with their performance and they're worried about how they're coming across. And here they're making sure they don't lose control. Now, notably, she can achieve orgasm alone with rapid mechanical stimulation, but never with a partner that she's had now for 4 years. And that distinction is critical. You see, the analysis labels this a completion interference imprint. Arousal is present, but the cognitive system remains on guard, monitoring for threat or shame. That monitoring blocks the surrender required for climax. This is not a lack of desire or arousal sensation. This is inhibition at the moment of completion, and the table here walks us through these differentials. So if you have medication versus imprinted arousal, with the SSRI-induced dysfunction, the patient describes this numbness, which requires intense stimulation, and the difficulty affects solo sex as well. It often is also dose and time dependent. With imprinted arousal pattern driving the issue is distraction and vigilance. So orgasm is possible alone, but blocked in partnered context where relational threat becomes activated. Clinically, the action follows the mechanism. So if the medication is driven, then you adjust the dose or augment, but if it's imprinted arousal, then you need to work on the cognitive system using mindfulness or sensate focusing rather than just escalating the stimulation, which breeds more frustration and then physiologic pain and problems. So the key takeaway is this: where orgasm is possible tells you why it is blocked. Where it is possible tells you why it's blocked. So on the left, you see the DSM criteria for genito-pelvic pain and penetration disorder. Now, this diagnosis requires the persistent or recurrent difficulty with penetration and vulvovaginal or pelvic pain, and it's associated with fear or anxiety about the pain, so it's anticipatory pain, which leads to some sort of involuntary pelvic floor tightening. And this is where vaginismus has been rolled into this diagnosis now. And symptoms have to be present for at least 6 months, which cause clinically significant distress, and they can't be better explained by another medical condition or some other non-sexual mental health problem. So in primary care, they'll often see their gynecologist or primary care, and they will say things very straightforward. Patients will say things like, it hurts too much to try. Or they may avoid gynecologic exams and describe repeated painful attempts that eventually lead to complete avoidance of penetration and care. Now, on the right side, you'll see this imprinted arousal pattern mapping. And this pattern sits primarily in that threat-fear domain with associated autonomic defensive activation and somatic guarding. And the key pattern here is the pain-threat imprint. Penetration has been conditioned as dangerous. And so the body initiates a reflexive defensive contraction or guarding even before conscious consent or desire can come online. So as a result, arousal becomes linked to anticipation of harm rather than pleasure. So the clinical shift here is essential. This is not a willful avoidance or a lack of desire. This is a learned protective reflex embedded in the nervous system. You may also notice, again, about the vaginismus. That used to be a very popular term as a standalone, and it's bundled into this genito-pelvic disorder. So clinically, it reflects the pain and guarding. Okay, let's talk about this genito-pelvic pain scenario here. So on the left, you see this vignette of a 29-year-old woman who reports a painful first intercourse at the age of 20. And since then, she experiences panic at the thought of penetration. Now, her physical exam would show no organic pathology, but her pelvic floor muscles tighten reflexively as contact is anticipated. So the analysis here is highlighting a pain threat imprint, and her nervous system has learned to predict pain. That prediction alone is enough to activate a defensive guard response, and that tightening occurs before penetration and even before conscious choice. This is a learned reflex in the somatic and threat domains, not a voluntary response. Now, on the right side, you'll see the differential organic versus imprinted arousal pattern driven. Now, with organic or medical causes, pain is consistent across contexts, regardless of partner, arousal, or emotional safety. And some conditions that can cause that would be things like endometriosis, or vestibulodynia. Now, with imprinted arousal pattern, the pain or tightness is cue dependent, and it's linked to the anticipation, anxiety, or specific relational context, and may occasionally lessen when safety or arousal is unusually high. Now, the clinical action follows directly. You need to rule out those organic causes first, and if those are negative, then treatment needs to focus on threat deconditioning and gradual exposure. So cognitive behavioral therapy is a big player with systematic desensitization. And you also need to address the learned pain response rather than forcing the penetration and re-traumatizing. Now, substance-induced dysfunctions are increasingly common, especially with the ubiquity of marijuana and alcoholism. In order to qualify for this diagnosis, the agent they're on has to be able to trigger the dysfunction. So the agent has to be capable, and it can't be better explained by something else. And keep in mind your substance can include prescription medications. And the most common ones are the SSRIs and SNRIs, as they cause delayed orgasm and anorgasmia. But opioids leading to hypogonadism or low desire. Alcohol also contributes to erectile dysfunction. It's also the leading cause being hypertension of erectile dysfunction. Delayed orgasms, antipsychotic use can raise prolactin level and inhibit arousal and desire. And on the right, you can see that the mechanism mapping to the imprinted arousal pattern reflects an exogenous override. So pharmacologic agents can mechanically suppress or reward arousal circuitry. But what I'm describing now is this chemical ceiling. So when arousal repeatedly hits the ceiling, it can unmask a weak, pre-existing imprinted arousal pattern, and that can create new frustrations and threat conditioning over time. So below is the key thing to pay attention to. Look at a dose-time correlation for the medication or substance. So you're asking whether the sexual change is aligned with a dose increase or steady state. And patients are often attribute everything to medication, sometimes to avoid discussing an underlying arousal pattern. So you need to have a careful evaluation of timeline. And finally, that differential, the medication typically will cause a global impairment across multiple contexts, alone, with partner, with multiple partners, etc. But if it's an imprinted arousal pattern, you will find that the difficulty is situational, often present before the medication, and sometimes then just made worse by the medication, and it will also persist after medication washout. So that's a good way to tell if this is medication-induced or not. So what do? You want to optimize the agent as much as possible, have them on the lowest possible effective dose, consider antidote therapy, or and then if it's an imprinted arousal, you want to shift arousal retraining when the pattern is not purely pharmacological. So the purpose of this slide is to bring it all together, and how do we tell? So here is a 5-step clinical pathway for distinguishing medication-induced sexual dysfunction from an imprinted arousal pattern dysfunction. Now, step 1 is time analysis. You're asking a simple but powerful question here. You have to ask, did the sexual change begin after the medication was started or the dose was increased? If it clearly coincides with meds, think medication-induced first. But if it predates the treatment, then an imprinted arousal pattern is already on the table for consideration. Now, the second thing is to cross-context check. Medications affect globally, so they show up with dysfunction across partner and solo and sleep and fantasy, etc. But if it's an imprinted arousal pattern, this is typically situational and often appearing only in partnered or specific relational context. Step 3 is the challenge test. So if you reduce the dose or allow a washout, does the function return? If it does, that supports the medication effect. And if nothing changes, well then imprinted arousal tends to be more likely. The fourth step is this imprinted arousal screening. Now you're looking for a regulatory history. Did arousal once serve as a coping strategy for safety, control, threat regulation earlier in life? If yes, that strongly confirms an imprinted arousal pattern. Finally, step 5 is when you bring it all together in synthesis. Many patients fall into a mixed picture. In those cases, the treatment plan is not either or. You have to optimize medications while simultaneously beginning this arousal retraining. So this pathway keeps the assessment structured and efficient and clinically grounded. This slide summarizes the core evaluation questions that I use when assessing sexual dysfunction, especially when I'm trying to distinguish an imprinted arousal pattern from a primary medical or medication-induced pathology. So the guiding principle here is stated across the top. Key inquiries will differentiate imprinted arousal from medical pathology. And so if you only ask what turns someone on, you're likely going to overdiagnose a lot of things. And if you ask why and when the arousal learned that role, then you begin to understand why the nervous system is responding the way it is. So the first question is not optional here. It's necessary. Are specific cues simply a preference, or does sexual response fail completely without them, right? So you're trying to distinguish, is this an optional thing or an essential component to your arousal? This helps you assess flexibility versus rigidity. Rigidity suggests the conditioning rather than just simply taste. Next is this first memory and context. You're asking when the pattern first appeared and what was happening emotionally or relationally at the time. Sexual patterns almost always emerge in response to a developmental or relational moment, not randomly. The third domain is this regulatory function. What emotional state tends to precede the urge, and what happens immediately afterwards? Do you feel relief, calm, disassociation after arousal? That often indicates a regulatory role rather than pure desire. In other words, these are the I feel horny all the time and I don't know why. Well, it's regulating those emotions. Finally, you always include a medical and medication screener. New medication, substance use changing, medical diagnosis that may coincide with the symptoms have to be ruled out before attributing a meaning to the pattern. So taken together, these questions are going to shift your assessment from just simply symptom labeling to understanding the function and timing and context, which is essential for an accurate diagnosis and effective treatment planning. All right, now we're going to set the stage for distinguishing the paraphilic disorders, and the most important points are clearly stated here. Sexual interests do not become pathological just because of their content. They have to be rigid, cause distress, impairment, they have to be compulsive, or cause harm in order to be labeled a pathological or a disorder. So for example, what is the difference between a paraphilia and a paraphilic disorder? Well, a paraphilia is simply an intense atypical sexual interest. It only qualifies as a disorder if it causes clinically significant distress or impairment, or if it involves non-consenting individuals. And many people have atypical interests that are stable and consensual and non-impairing, and those don't meet the criteria for a disorder. Next is this duration criteria. So symptoms have to persist for at least 6 months. And this helps you exclude these transient desires of experimentation and developmental curiosity, or just temporary stress-related regression. Now, during duration signals, they will consolidate rather than fluctuate also. So the third anchor is this non-consent threshold, which is absolute. So any sexual behavior involving a non-consenting person or someone unable to consent automatically puts it in the disorder category, regardless of whether the individual reports distress or not. So consent overrides all subjective experience when it comes to the paraphilia. Finally, this issue of risk stratification, this is important because it's one of the most common reasons referrals will come to psychiatry in the paraphilias. Evaluation focuses on the rigidity of the interest and the risk of acting on harmful urges versus just maintaining a fantasy life alone. The clinical task here is not about your moral judgment. This is about assessing for escalation and loss of control and dealing with potential harm. So that's the core principle that will guide you for the rest of the paraphilia section. We're diagnosing based on function, impact, and risk, not whether the interest or the content makes you uncomfortable. So a paraphilia, meaning an interest, is not the same thing as a paraphilic disorder. The threshold is distress impairment, or non-consent. Content alone is never sufficient, and the first requirement is a core symptomatology and duration. There has to be a recurrent, intense sexual arousal expressed as fantasies, urges, or behaviors involving atypical objects or activities, and this pattern has to persist for at least 6 months. This duration requirement helps you distinguish between some sort of enduring pattern or a transient curiosity or just a situational stress response. Next is this distress impairment. So the urges, fantasies, or behaviors must cause clinically significant distress, or it has to impair some functions of life, that is social, occupational, or some other important area. Now, importantly, distress refers to the internal suffering or loss of function. The distress cannot be moral discomfort imposed from some outside source. That's the DSM criteria. I'm not looking to say right or wrong, I'm sharing their criteria. The third criteria is non-consenting involvement, and this is absolute. If the individual has acted on the urge with a non-consenting person or someone unable to consent, this diagnosis criteria is met, regardless of any reports of individual distress. And also, risk and harm always have to override the subjective experience. Now, DSM has special attention to specifiers and risk assessment. You need to indicate whether the individual is in a controlled environment or in remission. And the evaluation must include a comprehensive assessment of risk to self and others. Diagnosis here is inseparable from this ongoing risk monitoring. The takeaway from this slide is you diagnose based on impact, duration, and risk, not on the nature of the sexual interest itself. So this slide is helpful because it lists all the paraphilic disorders and how they're mapped to the RDoC domains and learned arousal patterns. And rather than treating them as an isolated or purely behavioral situation, the purpose here is not to normalize or condemn, but it's to translate the diagnosis into a mechanism. So if you start at the left side of the screen here, these are the DSM-recognized paraphilic disorders, and each one is paired with their respective ICD-10 code. Remember, from the prior slide, these diagnoses only apply when the threshold of distress, impairment, or non-consent is met. The middle column here is the RDoC domains involved, and you'll notice that there's a recurring emphasis on the positive valence, arousal regulatory, negative valence, and sensory motor and cognitive systems. That pattern matters because it tells us that these are not preference disorders, but conditioned regulation strategies. Now focus on the column here on the right. This is the clinical translation. So if you look at voyeuristic, this reflects a distance control imprint. So the arousal is paired with safety through observation without reciprocity. And distance regulates the threat. If you look at exhibitionistic disorder, this maps onto a shock arousal imprint. And arousal is tied to surprise, power, and momentary dominance. Often a brief spike in autonomic activation is also known. Voyeuristic disorder, this represents a proximity arousal shortcut. Arousal becomes conditioned to anonymous bodily contact, bypassing the relational engagement. If you look at sexual masochism, this aligns with a pain relief imprint. Pain or suffering is paired with soothing, regulation, and meaning, often learned as a way to stabilize the internal state, similar to those non-suicidal self-injurious behaviors. If you look at sexual sadism, this reflects to a power arousal imprint, and arousal here is conditioned to control, domination, or threat. And what's happening is you're linking excitation to an externalized regulation. The through line through all of this is that these patterns are learned arousal regulation solutions. These are not random deviations. This worked for them at a lesser degree at some point in time at an early stage of development. So the diagnosis tells you what category someone falls into. Imprinted arousal pattern mapping tells you why the pattern works for their nervous system, and then what treatments you need to address. Now here are 3 more paraphilias. continuing on from the previous slide. So the left side, again, will show you the diagnosis, the code, the RDoC domains. Now, the goal, again, is translation, not normalization. So if you look at pedophilic disorder, this is a dominant RDoC domain, which is in the positive valence, social process, and cognitive systems. Clinically, this maps to what we're calling a developmental fixation imprint. Arousal here becomes anchored to an early stage relational template, often before adult reciprocity, agency, or equality are neurologically encoded. So this is not a preference that developed later, but a fixation that failed to mature alongside normative relational development. The next one here is the fetishistic disorder. Here, the RDoC mapping emphasizes positive valence and cognitive systems. So the corresponding imprint here is this cue-specific arousal imprint. Arousal becomes narrowed to this specific object, texture, symbol, something that reliably activates the rewarding system. Clinically, the issue is not the object itself, but it's the rigidity and narrowing of that sexual arousal pathway. And then finally, we have this transvestic disorder, and this maps primarily to the positive valence and social process and arousal systems. The imprint here is that the identity arousal imprint, where arousal becomes linked to role, transformation, or a specific self-state. The arousal is less about the external partner and more about the internal regulatory effect of occupying a particular identity configuration. Now, across these three diagnoses, the same rule applies. The diagnosis only holds when the pattern causes distress, impairment, or non-consensual risk. So these developmental condition-based arousal solutions that became fixed because they worked for the nervous system at a particular point in time. All right, now this slide talks about how fetish rigidity forms. So if you use the imprinted arousal pattern framework to describe learning over time rather than just labels, the core idea is we're looking at a developmental trajectory of compulsive arousal. Now, rigidity tells us how early and how emotionally loaded and how regulating the arousal pathway became. The more rigid the pattern, the earlier and the more essential it was to stabilize the nervous system. Now, if we look at kink versus fetish mechanics, a kink is simply a chosen enhancement. It's the flexible, optional, and additive. And a person can enjoy it, but arousal does not depend on it. By contrast, a fetish is a learned requirement, and this is cue-dependent and often necessary for arousal. The system is no longer choosing the cue is choosing the system. The other thing is to note the drivers of rigidity. Rigidity increases with early onset and high emotional load. And the strength of the regulatory function that the arousal served. So this can wane over time. When arousal helps manage shame, fear, loneliness, or relief at a critical developmental moment, then the nervous system learns this works, don't let that go. We need this to regulate. That learning gets locked in, and then so the DSM versus IAP perspective here is the DSM just describes the end state. It's gone on long enough, you meet enough criteria, you're in the box. Imprinted arousal is explaining the learning trajectory, how the nervous system encoded the pattern in the first place. And this distinction matters clinically because diagnosis alone does not tell you what to treat. Finally, the clinical implication of this is we're not treating preference. What we're treating is an entrenched learning history. The arousal system has imprinted on a specific cue as a source of safety and regulation. So until that function is addressed, the rigidity will persist, regardless of insight, motivation, or behavioral control. So that's the takeaway here. Rigidity is not about stubbornness, right? That compulsive behavior is not stubborn. It's evidence of how well that pattern once worked. And still works, except now it's causing distress because it's not working all the way. So this slide gives you practical evaluation questions to help distinguish a kink versus a fetish versus a paraphilic disorder without moralizing and without over-pathologizing. So the first probe is always about flexibility versus necessity. You have to ask whether the interest is optional or required. Can arousal occur without it? Can it occur in other contexts? Flexibility suggests variation. Necessity suggests imprinted arousal pathway. The other thing is to look at the learning history, which is the IAP detection tool. Instead of asking what the interest is, ask when it became sexually important and what was happening emotionally at that time. Early emotional salience is far more diagnostically meaningful than the content of the interest itself. Third is to look at the regulatory function of this. Ask what emotional states tend to trigger the urge and what changes afterwards. Does the anxiety drop off? Do you feel less lonely? Does identity feel stabilized? If arousal is serving a regulatory role, you're not dealing with recreation, you're dealing with a nervous system management problem. The fourth question is this nature of the distress. You really want to clarify whether the distress is intrinsic to the pattern, that is, are you bothered because of a sense of loss of control and how rigid it is, or is this coming from primarily a shame, external stigma, social judgment, religious persecution kind of place? The DSM diagnosis requires, in order to qualify as a disorder, that the distress has to be internal, not something that's culturally imposed. The fifth question is this issue of consent and safety, and this is the non-negotiable threshold. If anyone is being harmed or involved without consent, the pattern meets criteria for disorder, regardless of any subjective distress, because safety always has to override the theoretical nuance here. So if you only ask what turns someone on, you're going to overdiagnose. So you have to ask why and when it was learned and what role it played. That will help you understand, and that's the shift from content to function. It's what keeps your assessment both ethical and accurate. So on the left side here, I'm going to go through the paraphilias in order that are in the DSM, and then we're going to talk about threat risk assessment. So here is voyeuristic disorder. Simply, this involves a recurrent intense sexual arousal from observing an unsuspecting non-consenting person who's naked, undressing, or engaging in sexual activity, and the pattern must persist for at least 6 months and either cause clinically significant distress or impairment, and the individual has, or the individual has acted on the urges. Non-consent is intrinsic to this diagnosis. The typical referral typically comes after legal involvement, and there's an escalation in compulsive behavior and overwhelming shame. These individuals frequently will feel isolated, and intimacy is often experienced as this threatening rather than something that's desired. If you map this to imprinted arousal patterns, this pattern primarily engages the positive valence social processing and salience domains, which is cognitive, and the core imprint here is what we're calling that distance control. Arousal here is conditioned to safety of being unseen. So distance provides regulation, and the absence of reciprocity reduces that threat. Direct interaction, mutual desire, or emotional exposure is usually experienced as overwhelming and unsafe. Now, the nervous system learns that arousal is safest when control is maintained through invisibility. So look at the clinical vignette here. This 28-year-old man with exposure to parental conflict paired with arousal, threat, hiding. And observation without participation became regulating for this individual. Over time, that early solution generalized into a compulsive adult pattern, which they then use to manage stress and anxiety. And the risk assessment panel at the bottom here, this is not optional, it's essential. So voyeuristic disorder carries an inherent risk because consent is violated by definition. So you have to assess for escalation, including when they progress from live watching to recording, then to distribution. Access to victims is a major indicator, and then technology, as well as the legal and interpersonal harm involved. So the key takeaway here is this is not about curiosity or sexual preference. This is a learned arousal strategy that regulates anxiety through distance and control at the cost of consent and intimacy.
Exhibitionistic disorder involves a recurrent, intense, sexually arousing fantasy or urge or behavior that's centered on exposing one's genitals to an unsuspecting or a non-consenting person. The pattern has to persist at least 6 months, and the individual has either had to have acted on the urges or experiences or have clinically significant distress or impairment. And the referral pathway is often similar to things like voyeurism, but with a different behavioral signature. Patients with exhibitionistic disorder are commonly referred through legal systems, such as arrests for indecent exposure or some sort of court-mandated evaluation, or they can be referred for escalation of urges described as this compulsive thrill-seeking, which is often phrased as needing the rush. On the right hand, you'll see the mechanism of the imprinted arousal pattern. That pattern primarily involves this positive valence system and autonomic arousal and social processing. The central imprint here is this shock arousal imprint. And in this imprint, arousal is not conditioned to intimacy or mutual desire. Instead, it's conditioned to the reaction of the observer, specifically the shock and fear and surprise. The sudden spike they get in autonomic arousal combined with the social dominance and risk becomes that prerequisite for the sexual release. And the nervous system learns that arousal requires intensity, visibility, and threat. So the clinical vignette here illustrates this clearly. The patient describes urges that build when he feels ignored or powerless. And that moment of exposure and the observer's freeze response creates a brief experience of visibility and power and some physiologic intensity. The risk of being caught amplifies the autonomic surge and strengthens that imprint over time. This may also lead to wanting to have sex in public places. The risk assessment section here is essential. You have to evaluate the escalation, whether the behavior requires increasing frequency or closer proximity or more public settings to achieve the same effect. So the setting matters. If they do this in proximity to schools or playgrounds, well, that's dramatically increasing the severity and the risk. Also, disinhibition is also critical to assess here because they may use substances in order to lower their impulse control in order to precipitate the offense. The key clinical message here is this: exhibitionistic disorder, it's not about the sexual expression or the attention seeking alone. It's a learned arousal strategy that regulates those feelings of invisibility and powerlessness through shock and dominance and autonomic intensity, and at the expense of consent and safety. So the DSM will tell you when this pattern meets criteria, but this imprinted arousal pattern explains why the shock and risk becomes so necessary to arousal. Okay, voyeuristic disorder. Again, moving from the DSM criteria to the imprinted arousal pattern mechanism and that risk formulation. So on the left, you see the DSM-5 TR criteria and the presentation. Voyeuristic disorder involves a recurrent, intense sexual arousal from touching or rubbing against a non-consenting individual, typically in crowded settings like the 6 train during rush hour. And as what happens with other paraphilias is that the pattern has to persist for 6 months and the individual has to either act it on the urge or experience a significant clinical distress or impairment. And the typical referral context here is important. Patients are often reported after complaints of inappropriate touching in a crowded space, subways, buses, elevators, concerts, or occasionally in workplaces. And early on, the behavior is frequently framed as accidental contact, which can delay the identification of the troubled person and therefore intervention. On the right side, you see this imprinted arousal mapping, and that pattern engages the positive valence system, the social processing, and the sensory motor system. The core imprint here is the proximity arousal shortcut. In this imprint, arousal becomes conditioned to anonymous, non-reciprocal body contact, rather than navigating reciprocal social engagement or intimacy. You see, the nervous system learned that a shortcut, Physical proximity plus touch equals rapid arousal and release. Well, this bypasses complex social negotiation and emotional risk, substituting sensory motor stimulation for relational connection. Clinically, this shortcut often serves a regulatory function. The combination of proximity, anonymity, and risk produces an intense physiological signal that can temporarily regulate anxiety and loneliness or emotional dysregulation. The crowd provides the cover, and the lack of reciprocity reduces that perceived interpersonal threat. The key insight here is that voyeuristic behavior is not simply about sexual contact. This is reflecting a learned arousal pathway in which the body, not the relationship, becomes the primary regulator. Over time, the shortcut becomes more rigid and more compulsive and more disconnected from conscious choice. So as with other DSM disorders, that will tell you when the pattern meets diagnostic criteria, but that imprinted arousal pattern explains how proximity and anonymity and sensory motor stimulation became fused into a necessary arousal condition. And so treatment must address that underlying learning history, not just the behavior itself. Let's consider this clinical vignette with a risk assessment of a voyeuristic disorder, which is essential for real-world practice. So on the left, you see the story of a 34-year-old man with a long-standing social history who works in a high-stress environment, right? His behavior is not random. It's situationally bound. Crowded subway commutes during periods of peak work stress. He describes a rush of power and connection that temporarily relieves his anxiety. Well, that language matters because what he's describing is not primarily sexual desire. What he's describing is autonomic regulation, and that contact produces a brief sense of relief and grounding and pseudo-connection without requiring reciprocal social engagement. The crowd provides the anonymity, the touch provides the immediacy, and the risk that provides the intensity. So the analysis makes this imprinted arousal pattern explicit. The behavior serves a regulatory function specifically aimed at anxiety relief, and the non-consenting contact is creating a distorted sense of connection without the perceived threat of rejection and evaluation or even emotional exposure. So this imprinted arousal pattern, you're getting proximity and sensory motor stimulation. They have become fused to regulate. On the right side, you see the risk assessment here, and this is where clinical judgment becomes critical. So, situational triggers. Crowded environments and periods of high stress reliably will precipitate the behavior, and this predictably means that the risk is foreseeable. It's not impulsive in the narrow sense. Second, this issue of impulse control. So there's this concept of escalating frequency and this inability to delay gratification despite known consequences. And so you get signal progression from opportunistic behavior toward compulsion. Well, this raises concern for worsening severity. Third, you see here legal risk. Well, multiple complaints dramatically increase the likelihood of arrest. And at this stage, legal consequences are not hypothetical, they're imminent. Finally, this issue of consent violation. This is a direct, non-consensual physical contact. So regardless of the patient's internal experience or regulatory needs, the behavior violates bodily autonomy and carries that inherent interpersonal harm. So the main thing to take away is this. You need to understand the regulatory function that's explaining the behavior. But it doesn't excuse it. It just explains it. So effective treatment has to simultaneously address risk containment, legal and ethical responsibilities, and retraining of the arousal regulation pathway so that anxiety relief is no longer dependent on violating others. This is the difference between merely labeling a disorder and actually formulating it in a way that protects both the patient and the public. Sexual masochism. So this is how arousal becomes a regulatory pathway rather than merely a preference. So if you look at the left side, you have the DSM criteria. Sexual masochism disorder involves recurrent, intense sexual arousal from being humiliated, beaten, bound, or made to suffer, persisting for at least 6 months. And it has to cause clinically significant distress. So something to pay attention to here is the issue of risk. When the behavior introduces danger, particularly asphyxiation or physical injury, it removes this is just innocent play, and this makes it decisively more of a disorder. So the typical pattern here is a patient rarely presents because of the desire alone. They will present because of injury risk or escalating compulsivity, or because partners are refusing to continue to participate in what is increasingly a dangerous scenario. And the system is no longer flexible. Remember that mental rigidity is a tell of psychiatric disorder. Now look at the imprinted arousal mapping here on the right side of the screen. So what you see here is this core pattern of pain relief imprint. And the nervous system has learned that high intensity threat or pain is the gateway to soothing and regulation or some sort of meaning. So in other words, the suffering becomes the prerequisite for the relief. And the sequence is not pain for pleasure, it's pain as the fastest route to down-regulate. So you might see this in non-suicidal self-injurious behavior. This explains the RDoC domains involved. You have reward, arousal, and threat. So here you have high autonomic activation followed by abrupt quieting, which teaches the brain that the extreme input is necessary to feel calm. So the vignette will make this clear. So you have a 30-year-old man who uses breath restriction to manage his anxiety. His statement is, "It's the only time my brain goes quiet." That's diagnostic. This is not about sexual novelty. This is about shutting off internal noise through hypoxic threat. The recent loss of consciousness and the ER visit that follows mark this transition from risky behavior to potentially lethal behavior. So the analysis ties this together. You have physiologic survival threat, hypoxia and pain, and that has become paired with psychological relief. So the nervous system has learned that danger equals safety. And that learning history is the treatment target. Now we have to move to risk and safety planning, and this is non-negotiable. First, you have to concern yourself with lethality. You have to directly assess for breath play, blood restriction, solitary practice. Autoerotic asphyxiation carries a real risk of accidental death, especially when practiced alone. Second, the issue of consent. So you have to distinguish negotiated, safe, sane, consensual BDSM from reckless or escalating behaviors where consent is compromised or overridden by the compulsion. Third, this is where harm reduction comes in. So you want to avoid solitary restriction, and you have to establish firm, safe words that are met and obeyed. You also need to ensure medical evaluation for any sort of nerve or vascular injury, and you want to have safety planning discussions that does not endorse the behavior. When you have a safety discussion in these situations, it's not to say you're condoning this. The goal is that you're preventing death while deeper treatment is underway. So the main thing to take away from this is sexual masochism disorder, we're not treating pain-seeking. We're treating a nervous system that has learned that the extreme threat is the only reliable way to feel regulated. And until that learning pathway is addressed, risk will continue to escalate. So this is why imprinted arousal framework adds value beyond the diagnosis. So by telling you why this behavior is the way it is and where the intervention should occur. Okay, let's talk about sexual sadism disorder. This involves a recurrent, intense sexual arousal from physical or psychological suffering of another person. So the diagnostic threshold is met when the individual has acted on these urges with a non-consenting person, or when the urges are causing them clinically significant distress or impairment. As with the other disorders, this pattern has to persist for 6 months, and the typical referral reason here is different in tone than what I've previously told you. These patterns are often referred through forensic pathways after an assault or some sort of legal involvement or some sort of escalation by partner complaints. Unlike masochism or fetishistic patterns, presentation here is rarely voluntary and it's often externally mandated. Now, if we look at the IAP mapping, the imprinted arousal, which is essential for understanding this power arousal imprint, arousal is conditioned to the exertion of control and domination, or it's the induction of fear. The reward response is not triggered by pain alone, but by the other person's vulnerability. The perception of fear, submission, helplessness, that's what activates the reward while suppressing empathic inhibition. So the RDoC domains reflect this because you'll see a reward, threat, and social dominance structure here. Threat here is not avoided, it's required. And social processes here are not reciprocal, they're hierarchical. And this is what makes the disorder inherently dangerous. So take a look at the clinical vignette of a 35-year-old man who was initially engaged in consensual BDSM. Over time, he began ignoring safe words and escalated to non-consensual strangulation. Well, his statement is, "It doesn't work unless I see real fear." Well, that's a diagnostic core. That arousal system now requires authentic threat to function. The analysis is crucial, and you need to state this explicitly, in your mind at least. Arousal requires the reality of threat and the total subjugation in order to trigger the reward. This is no longer role play. Consent has been overridden by the learning history of the arousal system. So the transition to risk assessment is not optional in this situation. So the first thing you need to consider is an escalation trajectory. Does the arousal require increasing levels of injury, terror, or loss of control over time? Escalation is common because habituation reduces the reward signal unless the threat intensifies. So listen for that. Second, victim access. So you have to assess access to vulnerable individuals or partners who cannot reliably withdraw consent. Opportunity here is a major determinant of risk. And third, this issue of consent distortion. Many individuals will conflate fear or submission with consent. This is not a philosophical disagreement. It's a dangerous distortion that predicts recidivism. So the main point here is that sexual sadism disorder is not about sexual preference or a kink gone wrong. It's a conditioned arousal system that requires another person's fear or harm to function. That learning history is fundamentally altering the risk and the ethics and the treatment priorities. So this is where DSM tells you when to diagnose, but that IAP framework is telling you why this pattern is dangerous and why safety has to come first. All right, let's discuss pedophilic disorder. This is defined by a recurrent sexual attraction to prepubescent children, generally ages 13 or younger. The pattern has to persist for at least 6 months. The individual must be at least 16 years old to qualify for the diagnosis and at least 5 years older than the child of interest. And as the same with other paraphilic disorders, the diagnosis is met if the individual has ever acted on the urges or the urges are causing significant clinical distress. This is not about orientation or preference. This defining feature is the object of the arousal. They are attracted to, drawn to pre-adult children, combined with the risk of harm. So typical referral pathways for this is often through a mandated assessment, typically legal, forensic, family court. Self-referral is very rare and usually driven by fear of arrest rather than an intrinsic distress. So the mechanism of the imprinted arousal mapping, which explains why this pattern is so dangerous, is because what you're seeing here is a developmental fixation imprint. Arousal here is anchored to pre-adult relational templates, and the children are perceived as safe and controllable and non-threatening, and they're also perceived as high reward and low threat to the person acting. Adult intimacy, by contrast, is experienced as threatening and evaluative or even overwhelming. So the RDoC domains here are reflecting this learning history of reward and social processing and cognition. So the imprint is avoiding the complexity and mutuality of an adult relationship by fixing arousal at an earlier stage of development. Risk assessment in this is essential. This is not optional. So the first thing you need to assess for is access and opportunity. Does this individual have a professional, familial, or social access to children? Roles such as coach or caregiver, extended family member, all dramatically increase risk. Second, grooming behaviors. These often present as boundary crossing disguised as special attention, secret keeping, gifts, special friendships, or emotional exclusivity. Grooming is not incidental. It is a core risk marker. Third, the fantasy rigidity. You need to assess whether masturbation and sexual fantasy are exclusively paired with child imagery. High rigidity predicts persistence and escalation. Finally, you need to address the cognitive distortions that are listed here on the right side of the slide. Minimization statements such as, "I didn't hurt them," or "they were curious." That's what they're doing to reduce the perception of harm. The justification statements such as, "it was teaching," or "a special bond," or "love," that reframes exploitation as care. Well, these distortions are not incidental. They're what you call maintenance mechanisms of the disorder. So the clinical action is clear, and that is every distortion has to be challenged, and the risk has to be actively managed. So in many cases, external controls such as legal supervision, structured monitoring, pharmacologic suppression are necessary to protect children. The main thing to take away from this is pedophilic disorder is not defined by fantasy alone. It's defined by developmentally arrested arousal systems paired with access, cognitive distortions, and risk. So that DSM tells you when you've met the criteria. And the IAP framework is going to tell you why protection of the victims has to come first. Fetishistic disorder. This is one of the most commonly misunderstood paraphilias. So first, let's start with what makes this a disorder. In order to qualify, fetishistic disorder involves a recurrent intense sexual arousal from non-living objects or a highly specific focus on a non-genital body part. And the pattern must persist for at least 6 months and must cause clinically significant distress or impairment. Now, the key diagnostic point here is not what the object is, but whether arousal has become dependent on it. So clinically, patients will often say something very specific, like, "I can't get aroused without it." Well, that dependency is what's creating the distress, and then the partner's often feeling objectified or interchangeable or disconnected. So the conflict will usually arise not from the fetish itself, but from its rigidity. So if we look now at the imprinted arousal mapping, this is a cue-specific arousal imprint. So arousal becomes biologically locked to a specific sensory cue, like texture or smell or material or object, that was originally paired with something used for safety or comfort or regulation. So over time, the brain overlearns this pathway. So what began as an enhancer has become this exclusive route to activation. So from this RDoC perspective, you see that this sits at the intersection of reward valuation and attention salience. So the cue becomes disproportionately salient, and other sexual pathways weaken through disuse. So if you look at the vignette here, this will illustrate it. So in this example, the patient traces the fetish back to early adolescence. During a period of severe bullying, a leather jacket functioned as psychological armor, as protection, grounding, safety. Well, the nervous system paired that sensory experience with relief. And then over time, that regulatory cue became eroticized. So this is not a pathology by moral judgment, it's just a learning history encoded into the arousal system. So let's discuss the difference between kink versus a disorder. So on the right here, you're going to see a fetish as a kink is optional, flexible, and enhancing. That's what distinguishes it from a disorder. With a kink, arousal can still occur without it, and there's no distress. A fetish as a disorder is required. It's rigid, it's exclusive. Distress or impairment follows either internally or within the relationship. So the primary risk here is not violence or non-consent. The risk is relational collapse. When the partner cannot accommodate the rigidity or feels replaced by an object, that's what's qualifying this as a fetishistic disorder. Okay, let's talk about transvestic disorder. So on the left here, you see the DSM-5 criteria. Transvestic disorder involves a recurrent, intense sexual arousal from cross-dressing expressed through fantasies, urges, or behaviors. And the pattern has to persist for 6 months or longer and has to cause clinically significant distress or impairment, and most often it occurs in social or occupational domains. The critical diagnostic boundary here is this. The diagnosis is about sexual arousal, not gender identity. It has to be clearly distinguished from gender dysphoria, where the core issue is gender incongruence rather than just erotic activation. Clinically, patients will often present with this intense shame, secrecy, some sort of marital conflict or anxiety, and many will report difficulty in becoming aroused without the clothing cue. On the right side, you see the imprinted arousal mapping. This pattern is reflecting an identity arousal imprint. The arousal has become conditioned to transformation or role shifting. So adopting a different persona can provide psychological relief, often from stress or pressure or role overload. And that relief becomes coupled with a sexual reward. So over time, the nervous system learns that arousal requires a temporary suspension of the everyday self. So from a research domain criteria, this is dealing with the reward, social processing, and arousal regulation, and they're working together. The clothing is not inherently sexual. It just functions as a cue that permits identity loosening and emotional downregulation. So take a look at this vignette here. So it illustrates that periods of high stress, the patient dresses in his spouse's clothing and experiences a combination of soothing relief and sexual excitement, followed by guilt. Well, he reports difficulty performing sexually without the clothing cue, despite an intact attraction to his partner. So the imprinted arousal formulation will show you that the behavior is being used to regulate stress through a temporary identity suppression, with arousal reinforcing the pattern. The risk section here is important because we're dealing with shame that's driving secrecy, while secrecy increases the erotic charge, and the guilt leads to purging, followed by anxiety and a renewed compulsive behavior. So over time, this cycle increases isolation and functional impairment. Management here focuses on reducing shame and increasing flexibility and separating identity regulation from sexual arousal, rather than attempting to eliminate the interest itself. The main point to take away here is that transvestic disorder is not defined by cross-dressing. It's defined by dependence and distress and the nervous system's reliance on identity transformation as the required gateway to arousal. All right, let me talk about these 3 of the 5 core domains with respect to doing a risk assessment to evaluate any paraphilic disorder. The first domain that has to be considered for any risk assessment is this issue of consent and capacity. That's the highest priority because it determines immediate safety. So the key questions are not whether the behavior involves whatever the behavior involves. The main issue is non-consenting persons, minors, vulnerable adults, whether there is force, coercion, manipulation, or deception. If you have those, that's the violation. So any affirmative finding elevates that situation to an urgent safety concern and overrides any other consideration. So when consent is absent or capacity is compromised, the risk management takes precedence over any diagnostic nuance. The second domain is this access and opportunity. So here, the focus is on whether the patient has practical access to potential victims. So this will include, be it in their occupational or family role, whether they're a caregiver, or they're in environments that increase that risk or exposure. So what you're assessing is, tell me about your daily routines, your commuting patterns, your living arrangements, your unsupervised settings that create repeated opportunities. You're also evaluating whether there is external supervision or monitoring, and whether environmental controls are present or absent. The third domain is escalation and control. So this domain is evaluating the trajectory. You assess whether the frequency or intensity of urges or behaviors is increasing, and whether there has been a shift from fantasy to action, and whether the individual reports loss of control despite negative consequences. A history of impulsive acting out, legal involvement, or repeated boundary violations suggests that diminished inhibitory control and rising risk is a factor. So together, these three domains establish that initial risk profile by answering those three questions. Number one, is anyone being harmed or placed at risk right now? Number two, does the patient have access and opportunity to act? Number three, and is the pattern escalating or becoming harder to control? Now, these are the other two domains that help you complete your risk assessment framework, because it adds contextual factors that will either increase risk through disinhibition or reduce risk through protective factors. And these factors do not replace the primary safety domains mentioned previously, but they are meaningfully present because they can modify the overall risk assessment. So the first one addresses co-occurring risk factors, or disinhibitors. And the major one is, of course, substance use disorder, because it's a major amplifier of all risk across the board. Alcohol and other substances that, known to lower impulse control thresholds, increase the likelihood that urges will move from fantasy to behavior, particularly in individuals with pre-existing compulsive patterns. Comorbid psychiatric conditions further elevate risk, especially if there are impulse control disorders or antisocial traits or manic states. Those are especially relevant because they impair judgment and increase risk-taking behaviors and weaken any sort of internal restraint. Other factors to consider would be cognitive distortions. These are critical to identity. Statements like "they wanted it," or "I was teaching them," or "no one was harmed," those signal a moral disengagement and predict a higher likelihood of reoffending. So these distortions are reducing any internal barriers to act on urges. Acute stressors also increase vulnerability. So life stress, crisis, a sudden loss, periods of destabilization, all of that can trigger regression to some earlier arousal pattern, especially when those patterns are severe and they serve a regulatory function. So the second section here focuses on the protective factors, and these are ones that buffer the risk and will help inform your treatment planning. So if they have good insight and motivation, good genuine internal motivation to change is very protective, whereas purely external compliance, that is to say something that's court mandated or coerced or at the end of an ultimatum, that offers a lot less protection unless they develop insight over time. Social support also reduces isolation and increases accountability. So any stable, pro-social relationship can interrupt secrecy and reduce opportunities for acting out. So treatment engagement through groups or one-on-one is also a strong protective factor. Consistent attendance, willingness to discuss urges honestly, and adherence to medication, those are all considered risk-lowering factors. Finally, structure matters. So employment, predictable routine, reduced idle time, limiting exposure to triggers, and all of those will decrease opportunities for escalation. So the key takeaway from this slide is that risk is very dynamic, and disinhibitors can rapidly raise that risk even when baseline factors appear controlled. And protective elements can meaningfully reduce risk when consistently present. So an effective risk assessment requires tracking both the co-occurring risk factors and the protective ones over time and subsequently, not just at the initial intake. So this slide highlights the gap of what clinicians will routinely see and what the DSM formally codes. So the DSM is a categorical manual. It requires a clear syndromic boundary that's reliable across raters, and there's a consensus threshold. As a result, many clinically impairing compulsive behaviors that are treated in practice are excluded from the DSM. The first and most common one is compulsive sexual behavior, often loosely called sex addiction. And this pattern is widely treated in clinical areas and specialty settings, but it's excluded in the DSM. So patients will often present with a loss of control, escalation, secrecy, impairment, but without a formal DSM diagnosis. And so coding and framing are just like, well, I don't know what we're treating here. So it's indirect. Second, pornography use. Many patients experience problematic pornography consumption that causes relational, occupational, or psychological impairment. Well, this may not meet criteria for a paraphilic disorder, but the functions compulsively and is frequently tied to mood regulation and anxiety relief. Third, you may see shopping or buying behaviors or compulsive spending, commonly linked to affective regulation, stress relief, or identity reinforcement. Despite clear impairment in some patients, it lacks a formal DSM. And in that, you can start to tack on things like internet addiction, social media, excessive gaming. It's providing the same relief. Another big one is food addiction. This would be outside binge eating disorder. Some patients show a rigid dependence on specific foods or a continuous grazing pattern that does not meet binge eating disorder criteria, but still, it functions in a compulsive manner and it impairs health or daily life in some way. Another one that often gets missed is exercise addiction. This involves compulsive physical activity despite injury, medical risk, social interference. The behavior is reinforced by anxiety reduction or identity maintenance rather than health alone. And this sixth one, in New York, this is a virtue, work addiction. This is often normalized as workaholism. This pattern is driven by anxiety and avoidance and identity validation, and it can produce burnout, relational harm, and medical consequences, all without fitting a DSM diagnosis. So the key point is at the bottom of the slide here. These patterns are phenomenologically consistent with imprinted arousal pattern mechanisms, even though they lack a formal DSM categorization. They follow the same logic of conditioned relief and reward and repetition under stress. So that final note really emphasizes that social media addiction also fits this framework, particularly through dopamine-driven checking, validation seeking, and compulsive engagement. So the imprinted arousal pattern explanation of non-DSM compulsions is the unifying behavioral compulsions under arousal regulation mechanisms. So these behaviors are not distinct addictions. They represent variations of a shared learning process in which arousal becomes that primary strategy for regulating any dysregulated internal state. Arousal functions as an affect regulation tool rather than a biological drive. And the specific behavior is learned mechanisms that the nervous system uses to downregulate distress, anxiety, emptiness, and hyperarousal. So some common pairings you may see: the nervous system encodes specific arousal inputs and regulatory solutions. So high stress, sexual release. Inner emptiness and anhedonia, novelty seeking, shopping, scrolling, cruising. Anxiety or threat, that will regulate with control, intensity, or compulsive anxiety activity behavior. Identity insecurity, that becomes performative, productive, work immersion. The behavior persists because it reliably alters an internal state, not because the intrinsic addictive property. So consider a 35-year-old man who's an executive engages in anonymous sexual encounters to manage intense occupational stress. He has no romantic attachment, and the behavior is described as functional and mood regulating rather than desire driven. Well, the IAP analysis is that chronic cortisol elevation paired with sexual arousal produces that transient autonomic downregulation. The compulsion is maintained by its regulatory effect, not by the hypersexual drive. Compulsive sexual behavior. Consider this vignette of a 38-year-old professional who reports recurrent anonymous sexual encounters occurring predictably after any high-conflict workday. Episodes increase during periods of sleep deprivation and occupational stress. The behavior provides that transient relief from anxiety and emotional pressure, followed by guilt and interpersonal strain. Attempts to suppress the behavior without alternative regulation strategies are generally unsuccessful. So the conceptual frame here is that sexual arousal functions as a learned affect regulation mechanism under stress, with associated impairment in occupational focus and intimate relationships. Or what about this 29-year-old male who reports nightly pornography use escalating in duration and intensity over the past year, and the use is described as compulsive and occurring despite intent to stop, and results in delayed sleep, decreased concentration, and relational withdrawal. The patient notes that the use is most intense during periods of heightened anxiety and ruminations. Well, the conceptual frame here is that the repetitive arousal paired with attentional narrowing serves as a hyperarousal escape mechanism, reinforced by immediate autonomic relief despite cumulative impairment. Or what about this behavioral addiction phenotype? Non-substance, right? So consider a 42-year-old male executive who demonstrates compulsive work engagement characterized by prolonged working hours, inability to disengage, and irritability during enforced rest. So productivity surges are followed by exhaustion and emotional numbing. Outside interests and relationships have progressively narrowed. Work intensity reliably reduces any internal anxiety and identity insecurity. Really, I am my work, essentially. The conceptual frame here is that reward-seeking behavior operates as an arousal-based regulation strategy with behavioral rigidity and functional impairment that will emerge over time. So patients often want a quick fix, but realize this didn't develop overnight, and there's no official pill or pharmacotherapy that is indicated for these. But pharmacotherapy through this imprinted arousal lens means we shift how we think about medication, because we have to remember, we're not trying to erase desire, and we're not trying to suppress sexuality. What we're trying to do is create a physiological window in which new learning becomes possible. So medication can regulate arousal. Therapy will restructure the meaning. And it's only that retraining over time that's going to change the imprint. So when a clinician is relying exclusively on an SSRI, they often see partial or unstable results. The SSRI can reduce the libido and dampen that physiological intensity, but doesn't do anything to alter that learned dissociation between arousal and regulation. So the body may feel quieter, but the mental urge remains intact. So patients often report that the behavior is still there, just muted and waiting. So this is why relapse is common when the medication is discontinued. The imprint has not been touched. Through the imprinted arousal lens, medications are facilitators, not cues, and their role is to lower background noise and hyperarousal and anxiety and compulsive drive so that the patient can stay present without immediately acting. Medication increases tolerance for the distress. It slows the system enough for conscious choice and a new pairing to occur. And this creates that therapeutic opening. So effective treatment, therefore, requires combination strategies. So medication, yes, to regulate the nervous system, but exposure, delay, and repairing are the things that are retraining that imprint. So the patient learns that distress can rise without immediate discharge. So that arousal does not require the old behavior to resolve. That regulation can occur through a new pathway, and medication can just support that process by making the distress survivable. It doesn't teach any lessons, but it makes the lesson more tolerable. And that imprinted arousal pattern, success is not seen as the absence of urges. Success is seen as the loss of urgency. And the imprint loosens when arousal no longer dictates the behavior. So that is the role of pharmacotherapy from an imprinted arousal pattern lens. So these are the medication strategies aligned with the research domain criteria rather than DSM diagnosis. And they target circuit dysregulation, not diagnostic labels. So before I do the specifics, it's important to state clearly that all of the pharmacologic strategies discussed here are off-label when used, and this is not considered medical advice for everybody. Please get an opinion from a medical provider. So it's all off-label if you're doing this for compulsive sexual behavior or paraphilia or any non-DSM compulsion. So the use here is guided by mechanism, not by formal indication. So in the positive valence domain, the target is cue-driven. So we would use naltrexone, which is used to blunt reinforcement and reduce the rewarding hit that's typically associated with the behavior. Topiramate may also be used to reduce craving intensity and weaken impulsive drive by dampening that excitatory signal. If you're dealing in the arousal regulatory domain, well, the goal is calming baseline nervous system tone. So gabapentin can keep you from being at a 10 and can reduce that generalized hyperarousal and hopefully improve the distress tolerance. Propranolol is good for reducing autonomic activation and the physical symptoms that often precipitate the acting out. If you're dealing in the negative valence domain, treatment will focus on threat, anxiety, and vigilance. So SSRIs may be useful, or SNRIs, to address any sort of chronic anxiety or an obsessive preoccupation. If you have a trauma-related nightmare situation, prazosin or can help blunt nocturnal hyperarousal because that could be reinforcing the pattern. If you're dealing with salience and cognitive domains, medications really are used sparingly. You might try low-dose antipsychotics, but that's on a case-by-case basis for rigid fixations or any sort of psychotic feature, but this is not a first-line treatment. Across all domains, the principle is the same. The medication basically lowers the noise of the circuit. They don't rewrite the imprint. They just enable engagement and retraining. Now, finally, a brief note here on orgasmic disorders. Cabergoline has been used off-label in select cases to address delayed orgasm or anorgasmia by modulating prolactin and dopaminergic tone. That's a very niche application, and it should be considered only after careful endocrine and psychiatric assessment. So the take-home here is medication is a tool. It's the retraining that's the treatment. Now, this chart outlines medication selections based on the RDoC domains that drive the respective behavior. So step one is to identify what is the problem. So you need to assess the symptom presentation carefully to figure out what is the primary driver. And the way you do that is you ask what is actually pushing the behavior in real time. If you discover that the pattern is reward or craving driven, well, this falls under positive valence. And the target is going to be anti-craving and reward. Naltrexone is used to reduce that reinforcement. Topiramate can be added to decrease craving intensity and impulsive strength. If the pattern, though, is marked by urgency and Physiologic pressure and hyperarousal, well, that's the arousal and regulatory domain. So that target is autonomic modulation. And so gabapentin can reduce baseline arousal and distress. Propranolol can also blunt sympathetic activation and physical urgency. So if the pattern, though, is driven primarily by anxiety and fear and threat anticipation, that's negative valence. And so we're going to target anxiety and anxiolysis, though we're talking SSRIs and SNRIs to deal with chronic anxiety and obsessions. Many patients don't fall neatly into a single domain, so you wind up doing mixed or complex presentations, and so you might need to prioritize, always need to prioritize safety, and you might use low-dose combinations of multiple agents. But pharmacology is only one piece of this. The retraining is the therapy. Okay, we're winding down now. So it's important that you remember that compulsive behavior is not a problem of excessive desire. Compulsive behavior is a learned arousal serving regulation mechanism. So the behavior persists because it works. It reliably changes that internal state. So when other regulatory strategies fail, compulsive behavior seems to keep going. Treatment, therefore, is not at suppression, it's at flexibility. So the goal is to loosen the rigid pairing between arousal and relief and to repair regulation with safer, broader relational inputs. And then when flexibility increases, you'll notice that urgency decreases. And when urgency decreases, risk decreases. With all this information, where do we begin? Start with the learning history. Where did you learn to act this way and why? Ask when the arousal first became useful and what state it was regulating at the time. And remember to focus on function over content. Two patients can have the same behavior with a completely different mechanism. Next, you always need to assess flexibility. Can the patient regulate distress without the behavior, even briefly? And remember to integrate assessment and treatment. Rule out underlying medical conditions and medications as contributors, and then you want to align the pharmacotherapy to the dominant RDoC domain. And remember to document risk clearly. Be explicit about things like consent capacity, access, escalation, impairment, and avoid moral language. Use functional language. Treat the learning mechanism, not just the symptom. So the DSM has provided diagnostic structure, but not a mechanistic explanation. The RDoC offered you this dimensional framework for understanding arousal and threat, reward, and salience. The paraphilia assessment literature emphasizes things like access, escalation, consent, distortion, and control. The sexual conditioning literature demonstrates that arousal is plastic and learned and modifiable and changes over time. So together, these sources will support a shift from just labeling the behavior to actually understanding how arousal is learned to regulate an internal state. And that shift will change how we assess risk and how we document care and how we treat patients ethically and effectively. Thank you for your time.